and this is singleton pregnancy of a cephalic presentation, and the vertex is engaged. So, simply put, a low-risk pregnancy and labor. We observed her progress of labor on partogram, as we should, and that's her partogram tracing. So just try to have a look at this partogram tracing for a moment before we discuss it. So, are there any questions about this tracing before we proceed forward to our questions?
دكتور
تفضلي.
بجهة السيرفكس في 4 خطوط، خطوط حمر وخطوط زرق، شو بيمثل كل خط فيهم؟
جهة السيرفكس؟ قصدك عن هاي المنطقة؟
بالضبط.
راح تلاقي أول إشي two labels دائما، واحد على اليمين وواحد على الشمال، عشان أقول لك شو السيمبلز. هون O is for descent, square is for cervix. بالعادة ما بكونش square للسيرفكس، في أحيان راح تلاقوها X للسيرفكس. اللاينز اللي فيهم O's these represent the descent. The lines اللي فيهم squares, in this case, in most cases you'll see X's. These represent the station. So, sorry, the O represent the descent and station, and these represent the dilatation. The first line is a slope of 1 centimeter per hour, and it represents that Laird line. And 4 hours after this descent, there's a parallel line, which represents the action line. Okay? Is it clear?
دكتور شكرا.
وأحيانا حسب the type of partogram ممكن تلاقوا هذا الكي موجود هون. ممكن تلاقوه بدل -2 -1 ممكن تلاقوه من 1 ل 5. Rarely, but that's also a variant of partograms. So, any other questions before we start asking questions about this partogram?
دكتور الهوريزونتال لاين اللي تحت اللي عنده تايم هذا applies for the entire thing يعني حتى لا عند السيرفكس والاشياء هاي.
Yes.
هذول seconds صح؟
نعم. The x-axis is the same, and these represent hours.
hours. يعني 4 hours 5 hours المكتوبين ولا لا؟
لا, that's 4 a.m., 5 a.m., 6 a.m., 7 a.m., 8 a.m., 9 a.m., 1 p.m.
اوكي بس عندنا الكونتراكشنز هنا we can't know قديش كان الديوريشن لكل واحدة صح؟
No, you could.
Okay.
Okay, and we'll discuss this later if someone has confusion about how to assess contractions, and it's one of the questions actually. So, anything else before we proceed to our questions? Hello?
دكتور بالother variants of the partogram بالdescent 5 represents plus 3 or minus 2?
5 presents plus 3.
تمام شكرا.
عفوا. Plus 5 equals plus 3. There are two methods to assess station. There's the older one, which is on this partogram, which you divide the whole stations into thirds. عشان هيك -1, -2, -3, and 1/3, 2/3, 3/3. And there is the newer one, which is more objective, by which we represent stations by centimeters. So 1 centimeter, 2 centimeter, 3 centimeter, 4 centimeter, 5 centimeter. Okay. But in general, even in those, you limit to 3 because we don't care about crowning when assessing progress. So, how would you judge the progress of labor in this partogram? That's the first question. Of course, try raising your hand so that I could listen to one of you guys at a time, please. Hassan?
يس دكتور. يعني مش متأكد بس يمكن progressing لأنه صارت على الساعة 8 dilation of cervix 4 سنتيمتر فيمكن بهاي الفترة يعني فاتت بالليبر.
Okay, fair enough. Does anyone have any other suggestions? Leif?
To progressing, but we should be alerted because dilatation is not going in the perfect rate.
Okay, that's a very good question. A very good answer too. Samah, do you have any a third answer?
It's across the alert line. So as he said, it's slightly slow progression. So we need to be alert for this.
Okay, fair enough. Are there any other suggestions from the rest of you guys?
دكتور لايك clear مش ميكونيوم أو blood stained.
Okay, fair enough. So here we're having what we call protraction of dilatation. Protraction meaning slowing. It's not arrest. So this is not normal progress. The easiest cheat for you guys, if it crosses any of the lines, that's a problem. If it crossed the second line, this will be termed arrest of dilatation. Okay? And if you notice that the descent here has already crossed the action line. So there is arrest of dilatation also. So this is totally not an abnormal progress of labor. So the next question is, what do you deem might be the most likely cause of this abnormality in the progress of labor? What could it be? Which parts of the progress of labor or the mechanisms of labor is it at fault?
دكتور
تفضلي.
ممكن يكون البسج يعني ال adequacy of the pelvis diameter لأنه أو البيبي ممكن يكون إنه حجمه كبير لأنه ال engagement أو الديسنت ما بيزيد مع الوقت مع إنه هو صحيح الكونتراكشن مش enough بس إنه في contraction بس الديسنت ثابت.
Okay. Does Mahmoud, do you have other suggestions? But who did speak lastly? Because they didn't raise their hands, so their name doesn't show up.
Because the contraction is stopped.
محمود صوتك كتير بقطع، فممكن تحكي بس شوي وتحاول تبعد عن الميكروفون.
لأن عندي شوي مشكلة في النت سوري.
لا مش مشكلة.
I said because contraction is stopped.
أنا سمعت because there's contractions بس. بتحب تكتبه بالشات إذا عندك مشكلة بالأوديو إحنا نقرأ. راح استناك لا تكتبه.
الدكتور أنا اسمه لا عفوا نسيت إنه لازم to raise my hand sorry.
مش مشكلة ولا.
دكتور في مجال أسأل سؤال قبل ما يكتب محمود؟
تفضل.
بالكونتراكشن سيكشن
راح احكي عن contractions. راح يكون في سؤال عن contractions، واذا حسيتني ما جاوبتك عن اللي بدك تسأله احكي لي، تمام؟ بس عشان ما نضلنا نعيد الشغلات اكثر من مرة ونضيع وقتكم، هاي هي بس.
Yes.
Okay, so Mahmoud says because the contractions has stopped. The contraction have not stopped, Mahmoud. So, if you want to analyze what might be the causes, you have to assess three issues. First, how are the contractions? That's step number one. Step number two, which part of the progressive labor is being impeded? Usually, if it's the dilatation, there's a problem with the contraction. If it's the descent, there's what we call some sort of cephalopelvic disproportion, which would mean that the problems with the passage or the passenger. So either the baby is larger than what's accepted by the maternal pelvis, or the maternal pelvis is unusually smaller than it should be. That's what these signify. Okay? Is it clear?
Yes.
Okay. So do we have risk factors from her history signify thus? Sorry. اعطوني ثواني بس في مشكلة لأن شكله فشات على السلايدات. فشات على السلايد. مش مشكلة. So, what's her risk factor for this problem? The only risk factor is she's a primary gravida. Otherwise, I see no significant risk factors from the history given to you guys in this title for this poor progressive labor. Okay. I'm just going to return to the partogram itself so that you focus on the curves. Now, what are the treatment options that we have for this lady? Can we suggest any treatment options? Okay, let me ask you another question, which should be easier for you. How would you classify her contractions, or how would you categorize the contractions that she's having at 10 and 11 p.m. a.m. Sorry. Yusuf? Hassan, عفوا. Yusuf.
دكتور contractions اللي على 10 للساعة 10
الساعة 10 أو الساعة 11 اللي بدك إياهم نقيهم.
تمام. They are 3 contractions every 10 minutes but they are moderate of intensity.
Okay, so she's having 3 contractions in 10 minutes of moderate intensity.
Yes.
Very good. And what do you mean usually by moderate intensity? Does anyone know?
That the contraction lasts less than 40 seconds.
Okay. Does anyone have another suggestion in regards to how to categorize the contractions at 10 a.m.? ولا؟
لا ما كنت بدي فكرت راح تسأل إنه كيف جاوب كيف يعني قسمناهم بس هو أنا جوابي نفس الإشي 3 contractions moderate لأنه لما يكون bold هيك غامق أنا بعرف إنه بكون الانتنسيتي حسب لون المربع يعني كيف معلم مثلا أول مربع بس هيك يعني تعقيبا على كلامه.
Just by the way, this is slightly an atypical type of partogram because most partograms, this is a digitized partogram. So it was not on paper and then scanned. This is a computerized partogram. That's why it's all shaded. But in most partograms, mild contractions are represented by dots. So if let's say she's having at 3 p.m., 2 contractions in 10 minutes and they're mild, I'll just dot these lines. Moderate contractions are by striped lines. And intense contractions are totally shaded squares. These are how partogram is illustrated during years. But in this case, because it's computerized, it's just shades. So I do agree, these are 3 contractions in 10 minutes of moderate intensity. When we say moderate intensity, that means lasting 30 to 45 seconds. If it lasts more than 45 seconds, these are intense. And if they're less than 20 seconds, these are mild. Fair enough?
دكتور لو سمحت ممكن تعيد الحكاية اللي قبل شوي 20 وال 45.
Okay. So in general, when we say it's a moderate contraction, it's a contraction that's lasting between 30 to 45 minutes from start to end, not from peak. So if it starts and ends within 30 to 45 seconds, that's a moderate contraction. And that's the type of contraction we prefer because that's the best type to enable good uncomplicated progress of labor. If it's more than 45 seconds, it's deemed to be intense. And if it's less than, some people say 30, but usually we say 20 seconds, that's a mild contraction. And these are the ones that need to be augmented. Okay? So, another question. What were the status of her membranes when she presented to the labor ward, this lady, according to this partogram? Laith?
Ruptured with clear amniotic fluid.
Ruptured with clear amniotic fluid. Okay. Does any of the rest of you guys have any other suggestions? Okay, they withdrew their hands. That means they agree with you. And I do agree with you too. So. Sometimes Google likes to speak out of place. So, you see the square? This is the line when she was admitted to the labor ward and the partogram has been initiated. The first square has the letter C. C means clear. That means there's revealed clear liquor. And that means that the lady already had rupture of membranes. On the other hand, let's say it was not C, it was MI. What does it mean? Hassan?
Hassan, doctor.
Hassan, sorry.
Meconium stained.
No, it does not mean meconium stained. MI or I. You either see either of those. Bayan?
Intact membrane.
Yes. That means intact membranes. On the other hand, if you see M, and some people actually write M plus also, that will signify meconium, and the plus that means that there's severe meconium. Okay. So that's the fetal part of the partogram. Let's go to the first case, which we should have started with. Here we have a 26-year-old lady. She's a primie. She presents at term and spontaneous labor. This is a singleton pregnancy with a longitudinal lie and a cephalic presentation. Her pregnancy has ended at 30, her previous pregnancy ended at 34 weeks with spontaneous labor at 2 kg. She's 150 centimeters tall. So sorry, this is not a primary gravida. She's para 1. Her pregnancy so far has been uncomplicated, but her midwife has told her frequently that the baby feels big. She has been in labor all day. She has been given oxytocin for the past 4 hours. So I'll give you a moment to go over it again. Just remember, she's gravida 2 para 1, not primary gravida. I opened the old slides by mistake. So do you have any questions about this presentation before we go forth? Okay. That's her partogram. Again, I'll give you a couple of moments to go over her partogram before we start discussing it. Sorry, my camera just broke for a moment. Okay, so again, any questions about this partogram before we start? So I'll presume that everything's clear about this partogram. My first question, so what would you say about this partogram? Does anyone have anything to say or to categorize this partogram? Samah?
The progression is arrested, so this is obstructed labor. Contractions, 4 contractions per 10 minutes, which is adequate, but the intensity is strong.
Okay. Yusuf, do you have another suggestion?
No, right, no obstructive.
Okay, so you do agree with Samah, as I do. So here, you'll see this lady started at 2 centimeter dilatation, and she was at -1 station during admission. Throughout her labor, that's the first 4 hours, that's the second 4 hour, that's 12 hours, the station has not changed. She has some change in dilatation, but it's still even slow. Because remember, ideally, she should have around 1 centimeter per hour. So the slope is normal. The initial slope is normal. But here, we're having even slowing of dilatation. That's secondary to the slowness of descent. Remember, if the fetal presenting part does not impact the cervix, does not exert hydrostatic pressure on the cervix does not dilate. The cervix is not muscular. It's just sort of a membrane of a connective tissue. What's the first thing we should look for whenever we see this poor progress? حسن؟
الفيتال هارت دكتور يعني نشوف
fetal heart is always evaluated regardless. But I'm talking about specific issues in regards to this abnormality in tracing.
Okay.
Philip?
دكتور ممكن بما انه احنا شايفين انه في عنا مشكله بالديسنت والنيرس او الميد وايف حكت انه البيبي feels big ف we might want to confirm انه اذا في مشكله عنا بالباسنجر نفسه اللي هو بالبيبي is it too big to descend through the mother's يعني pelvis او لا.
And how would you do that?
Maybe ultrasound أو physical examination يعني to confirm أكثر.
Now, ultrasound will be ideal to estimate the fetal weight, but there is a problem with ultrasound intrapartum. Ultrasound when the lady is in labor is usually inaccurate to diagnose the estimated fetal weight, because remember, the parts, the fetal biometrics that we need to calculate the estimated fetal weight are mainly the head circumference and the biparietal diameter. And because the fetal presenting part is currently compressed within the maternal pelvis, it's hard to visualize on ultrasound. And even if it is visualized, it's compressed by the pelvis. So it will give us smaller measurements than it actually is. But good of you that you noticed that the midwife has told her so. So the first thing you should notice are there any signs of obstruction during examination? And is she having adequate contractions in the first place? Now, Samah has already told us that she deems this lady has adequate contractions. And I do agree. Because she's having 4 contractions in 10 minutes. And they're moderate to severe intensity. So these are considered to be adequate contractions. When do we consider contractions adequate for the progressive labor? Would anyone tell me? Samah?
3 to 5 over 10 minutes.
Oh, that's a partial answer. Would you care to complete your answer?
Doctor, if they last for 30 to 45 seconds each.
Yeah, so we need the quality and the duration. So they need to be of moderate intensity and at least 3 in 10 minutes. That's one of the methods. That's the clinical way to judge adequate contractions. Is there another method? Does anyone know of another method to estimate the adequacy of uterine contractions for labor? Hassan.
Doctor, you mean يعني other than the partogram?
Yeah, in partogram we use the clinical method, which is done by palpation. How do we write these on the partogram? Well, usually a midwife or a doctor will just keep their hand on the uterine pelvis, on the uterine fundus, sorry, and they will palpate the contractions. Every time a contraction starts, they'll put a timer, and when they end, they put a timer, so they know the duration. And they keep palpating for 10 minutes to calculate how many contractions are there in 10 minutes. That's the clinical method. is there another method that's more objective but harder to allude to? Laith?
CTG Cocogram section.
Okay. By the way, it is utilizing the tocogram, but not due to in a CTG itself. Because CTG is inaccurate to diagnose the intensity of uterine contractions. CTGs do give you that the uterus is contracting, but the amplitude of the contraction is inaccurate. So our other method is what we call, if you've heard of it, Montevideo units. Have you heard of Montevideo units? فيليب تفضل.
لا دكتور، أنا بس كنت بدي أسأل شغلة هون عن سكويرز إذا ممكن.
تفضل اسأل.
أنا مش فاهم هون each square من الصغار what does it represent
أي صغار؟ أي صغار؟
تحت عند ال contractions per 10 minutes.
هدول يعني؟ هاي؟
Yes, each one الصغار
نص ساعة.
نص ساعة أوكي. طب مثلا إذا رحت على 4 o'clock if I went vertically كيف الإشي بيشتغل؟ يعني ليش إحنا يعني مش فاهم كيف بتعبوا.
تاني مرة بس سؤالك لأني ما فهمته. على 4 قصدك 4 AM يعني؟
مثلا احنا عبينا مثلا 30 minutes هنا 6 times، فكيف يعني هيك؟
In general, the midwife will assess the fetal heart if it's not on continuous fetal heart racing and the uterine contractions every 30 minutes. Okay?
اوكي.
عشان هيك محطوطين every 30 minutes هذول مفصولين. We judge the changes in the cervix and descent usually every 4 hours. Later on in labor it might be 2 hours or 1 hour even. عشان هيك هدول محطوطين in hours. Because we'll never judge نفحص على 4:30 وبعدين نفحص على 5. We'll never do that. Usually in the early labor it's always 4 hours. حتى هون حاطين لك السكويرز accurately at 4 hours. That depends on the frequency of observations. بس. Okay?
تمام، شكرا دكتور.
عفوا. راح أحكي عن مونتفيديو يونتس بعدين لحال مع ال CTG إذا أخذنا CTG or 2 عشان نوضحها. So we already had the answer of one of my questions, which are the intensity and the frequency of the contractions at 4 p.m. My next question is, at 7 a.m., what was her cervical dilatation? I'll just give you a moment to figure it out. So, by the way, this is the line of 7 a.m. Okay, Hala.
It was 5 centimeters dilated.
It was 5 centimeters dilated. Let's see the rest of your colleagues if they agree or disagree. Hassan.
Yes, دكتور. يعني بس 4 سنتيمتر يمكن.
Okay. Bayan?
Yes, 5 centimeters, I think.
Okay. So just draw a vertical line. We said that this is the 7 a.m. Draw a perpendicular line. And we know this curve is the curve of dilatation. So it is indeed 5 centimeters. Correct. The last question, or I have 2 more questions. What are the risk factors that we know of so far for this lady to have this kind of progress in labor? I'll return you to the title. بيان.
دكتور ممكن تعيد السؤال لأنه النت قطع شوي.
Okay. So what risk factors does this lady have from what we know about her to have this kind of abnormality in the progress of labor?
يعني الميدوايف حكت لها إنه the baby feels big. مش عارف.
Okay, so she might be having a large for gestational age fetus. Fair enough. Is there something else?
يس دكتور أنا رافع إيدي بس مش عارف إذا مبين عندك ولا لا.
كنت بستنى بس بيان تخلص. اوكي تفضل حسن.
ممكن I would say her height يعني ممكن affect that.
لا ممكن هو صح هذا the second risk factor that we have.
Yes.
Okay, so she might be having an LGA fetus and her height is 150 centimeters. Okay, these are both risk factors. Hassan or Izzy, do you have anything else to add? Because you still have your hands raised.
Doctor, previous preterm labor.
Now, previous preterm labor does not increase the risk of cephalopelvic disproportion. But the problem with previous preterm labor, especially of a smaller baby, it does not give us a good clinical test. The gold standard to judge clinical adequacy is trial of labor. But when you have a small baby of a very preterm baby that does not challenge the pelvic structures, so it's not an adequate test. Okay, so it signifies nothing for us. It doesn't help us to judge that the pelvis is adequate, even though she's short. It's just a confounding factor here. Okay.
So ممكن تكون pragmatic presentation.
ممكن تكون pragmatic presentation as like brow.
Yes.
We said this is cephalic presentation, longitudinal cephalic presentation. In general, if I did not tell you there's abnormality in the exam, okay, just consider it to have a normal presentation. Ideally, I would have told you this is vertex. But if she's brow, yes, she might be having cephalopelvic disproportion due to brow. So how should we manage this lady? What's the next step in management? Philip, في عندك إشي بدك تحكيه؟
دكتور كنت بدي أسأل لما حكينا إنه الهايت ممكن يكون risk factor. Would it still be a risk factor إذا كان البيبي of normal size؟ يعني considering إنه ببعض الدول this height is kind of the average for women.
Okay. In general, maternal height, regardless of the fetal weight, is a risk factor for CBD. In areas and places where the ethnic factors all propagate that the fetuses will be of normal weights, they will be of normal weights, but there'll be lower limit of what we consider normal. They'll be like 2.4, 2.5, 2.6 kgs. مش زي عندنا مثلا normal average 3.3. And that will impact the likelihood of CPD. وضحت الفكرة؟
Yes, شكرا دكتور.
Okay, and these are genetic factors. If the mother is 150 centimeters tall, her husband's usually 165, 170, if they're from the same ethnicity. The fetus will be on the lower centiles of normal for its gestational age, and thus there will be no CPD. But if that baby was 3.4, which is still quote unquote normal, it might cause CPD. Remember that, unfortunately, we still use absolute numbers, but the numbers for estimated fetal weights ideally should be based on population-based centiles. Yani, you do not expect a Scandinavian woman to have her height and her spouse's height and her baby's weights and heights to be of the same. إذا كان على 50 centile to be exactly the same absolute number of a lady from the Philippines whom height is 150 and her husband's 166, let's say, of the 50th centile. The 50th centile for Scandinavia, I'm just giving random numbers, okay? I don't have the centiles in front of me, but for Scandinavia, for instance, it might be 3.4. Their 50th centile, and for the Philippines 2.4 if it's under normal nutrition, of course. So that's one of the problems with the centiles we use. Even here in the Middle East, we don't have customizable centiles. Ideally, centiles for biometrics and for lab tests should be customized to the population. Not every population have the same numbers. Fair enough?
شكرا دكتور. Yes.
Okay. So the last question about partogram. What's the ideal treatment method? What Fiji should do? I'll give you a summary, which should hint you to the answer. We have a 26-year-old gravity 2 power 1. She's presenting with arrestive descent under adequate contraction with oxytocin augmentation. What's the treatment? Voila.
بما إنه البيشنت عندها effective contractions وما هيك ما صار في labor، فأتوقع الجواب إنه لازم نلجأ للسيزاريان section.
Okay, so we should resort to a cesarean section. Let's see if Hassan has another answer, or Hassan, Asif.
Doctor, why we don't do a episiotomy?
Why we don't do an episiotomy? Okay, I'll answer this briefly. Hala still has her hand raised. Do you have another answer, Hala? Okay. So I do agree with Wala. Here, this case, actually, we should resort to cesarean section. Okay. Now, I'm gonna change the curve slightly. Now let's see what you guys have to answer. I'm just gonna change the dilatation. She started at 4. I'm gonna write my dilatation in X's just to be more clear. Then she was 7. And here she was 9, and here she was 10. And that's our new curve. What should we do? And I'm gonna change the descent. and that's her descent. Is she still having a rest in descent? Okay, but how should we manage this arrest in this case? Hassan?
Okay, if we give her enough oxytocin and there is no progress, now we can proceed with the episiotomy.
Why episiotomy?
Because the head slightly descends and cervical dilatation is enough.
Okay. So you guys have problems of understanding what episiotomy is for in the first place. Leif, do you have another answer?
يعني دكتور dilatation is enough and the descent بلش يعمل crowning, so I think episiotomy will do the job.
Again, episiotomy. By the way, the answer is not episiotomy. Here you might resort to instrumental delivery. Okay. What do we use episiotomy for? Because there seems to be a problem with understanding the role of episiotomy in obstetrics. I'm just going to close the slides for a moment. Anyone care to tell me what episiotomies are for? Hassan?
دكتور هو يمكن it used sometimes in the prima gravida to release the intents of the pelvic.
Okay, and why do you want to release the tensity of the pelvis?
To ease the labor process.
What's your end goal? Is it to ease delivery of the baby?
Yes, my answer.
Does anyone have any other answers? هلا؟
هلا أنا بعرف الإبيزيوتومي بنعملها لما هلا البيبي already صار له engagement و past the orifice. إحنا بنعمل هيك بس مشان إنه dilate الopening ما بين الفاجينا والanus بس.
Okay. Now, episiotomy is done at maximum crowning, not engagement. Do you all understand what crowning is? Voila. What's crowning?
The encirclement of the largest head diameter by the vulval ring.
Okay. Yes. When there is a maximum, there are two definitions of crowning, but the one here I'm using is the one that Voila said. Okay. When there is maximum distension of the vulva by the presenting part. There are other definitions of episiotomy is when the vulva is irreversibly split by the presenting part, not the maximum. It's just split and doesn't close again due to the presenting part. But episiotomy is done at maximum distension of the vulva by the presenting part, not before. Why at that point? Because we'll do the most accurate, the least bloody, the least painful, and the easiest incision at that point. There are two purposes for episiotomies in obstetrics. Episiotomy is either done to try to prevent further vaginal lacerations, which is the most common indication. That's why primary gravidas usually have non-distensible vaginas and lower perineum. So we try to resort to episiotomy so that we control the laceration site instead of having multiple hard to suture lacerations. We do one sharp incision with good cosmosis later on. If you don't, there might be multiple lacerations, circumferential lacerations, and these are very hard to suture and might cause increased morbidity and even inlet sphincter injury. Okay, they're not the easy extraction of the fetal presenting part. They do not quicken the delivery of the presenting part. That's one. The second indication, which you'll never be asked about as students, I really doubt, is in dystocia. Whenever you have shoulder dystocia and you need to manipulate the fetus by what we call the internal maneuvers, just like corkscrew and reverse corkscrew, you need space for your hand, not just the presenting part. You need space for your hand to do these maneuvers. And that's when we attempt these incisions. And of course, it's obligatory for forceps assisted delivery. Okay, but it does not aid in quickening delivery of the fetus. Is it clear?
Yes.
اوكي، في حدا ما فهم إشي من اللي حكيته للآن عن بارتوجرام أو عن بيزيوتوم أو عن غيره قبل ما ناخد كيس أو تنتين من عن السي تي جي؟ إنه اوريدي مرت ساعة، وأنا بعرف إنه غير إنه بالعادة الناس يدوب بعد ساعة يصحصحوا رمضان، فاللي صايم فاصل حاليا. اوكي،
دكتور
تفضل. بس مين اللي كان بيحكي انه ما رفع ايده؟ ما بعرف اشوف الاسم.
رفعت ايدي بس كأنها ما بينت عندك، فمشان هيك
مش
حكيت.
مشكلة. منى؟ اوكي تفضل.
دكتور كنت بدي أسأل، يعني لو المريضة مش برايما جرافيدا ولا في عنا شولدر ديستوشيا، مش ضروري نعمل إبيزوستومي؟
تاني مرة لاني ما فهمت سؤالك. ممكن
إنه هلا لو المريضة مش برايما جرافيدا وما في عنا شولدر ديستوشيا لازم نعمل إبيزوستومي؟
نو، ولا حتى لو برايمري جرافيدا لازم اعمل بيزيوتومي. Episiotomy is way overutilized. In general, 3% of multiparals will have an episiotomy, and 70 to 80% of primary gravidas will undergo episiotomy. Okay? Even these numbers are exaggerated. We doctors are very fearful, and we're very impatient, and we resort to episiotomy. Okay? It's one of our faults. But in general, episiotomy is not a must for any indication other than forceps and dystocia. Otherwise, it's based on clinical judgment. What's the adequacy of the pelvis and the pelvic ring to deliver this baby without excessive trauma to the mother's genital tract? It's just to prevent excessive trauma to the maternal genital tract. That's the whole role of episiotomy. Okay?
Okay, شكرا دكتور.
عفوا. So, in general, these are the most commonly used instruments to do a CTG. You have a machine that interprets the Doppler signals using a computer to graphs. This machine has at least 2 probes. One is connected to the fundus to calculate the contractions. It's a manometer, in other words. And the other transmits the Doppler signals to the fetal heart to give us the fetal heart tracing. That's the most common type of tachograph using external monitoring. Of course, you might have multiple fetuses like twins. These will have, each of them will have their own signals. And would anyone care to tell me, what does this button do? Hassan?
Yes, Doctor. This is for the patient, I think, when the baby hits the mother's abdomen.
Yeah, this is the subjective fetal movement indicator. So whenever the mother feels that the baby's moving, she'll just click the button and it will give us on the chart an indicator that fetal movements were felt at this point so that we can correlate everything to each other. This is how a cardiotocogram is applied. Of course, this is not intended to be a lecture, but this is just orientation before we go through the cases themselves, because I realize cardiotocograms seem quite hard for you guys, although they're very simple. So the lower piece, which has US written on it because it's ultrasound. And that's the one that detects the fetal heart proper. The upper piece detects the uterine contractions. Here we have this tracing. Just take a minute to go over this tracing. These are, of course, for most cases, actual patients. Before we ask questions about these tracings. Okay, so which part denotes the fetal contractions in this partogram? Hassan? Fetal heart, sorry, contractions.
Doctor, the one in the above.
The one in the above. Wala, do you agree?
Yes, I agree. The upper line reflect the fetal heart rate.
Okay, so that's the fetal heart rate, and we agree. And which part reflects the uterine contractions? Wala?
The lower line reflects uterine contractions.
So the lower strip reflects the uterine contractions. And I agree. So that's the uterine contractions. Now here you see something some few circles. I'm circling with lines within them. Do you guys know what these are? I'm referring to these. I wouldn't expect you to be asked about them as students, but if you really want to know partograms, you have to know what everything that's written on the strip. And I promise you, some obstetricians do not know what these mean. Philip?
ممكن just make a guess يعني ممكن الفetal movements اللي هي that the patient or the mother reports.
These are fetal movements calculated from the monogram. Okay, not the ones that the mother reports. Okay. شايفون FMD fetal movement determination. فراح تلاقي كتير منهم في خطوط هيك كتير جنب بعض لما يكون في كتير fetal movements. And these are normal. And what do these lines represent? These circles. The arrows. The arrows are the ones where the mother reported the contractions. By the clicker that we saw before. Okay? Of course, in every partogram, we'll have graduations. For the fetal heart rate, usually we start at 40 or 60 and end at 220. And for the tocogram, we start from 0 to 100. At the beginning of every strip, it's not shown here, you'll have a strip here, and you have the patient's details, hospital number, and so on to make sure this is for this patient. And at the top of every piece of paper, there will be a serial number for medical legal reasons. زي ما بتشوف كيف المحلات اللي بيكتبوا فاتورة بالإيد، كل فاتورة لها رقم متسلسل عشان الضريبة. نفس الشيء، كل ورقة هون لها رقم متسلسل عشان ما حدش يغش ويقص ورقة. وبالنص أهم إشي بيكون time and date، والأهم منها الريت. Usually the rate is either 1 centimeter per minute, which is the most common one, بس في ناس بحطوا 3 centimeter per minute. زي ما أخذتوا بالإيكوكارديوجرام، إذا غيرت الريت ممكن تخربط بالinterpretation تبعك. So if you're used to one rate versus another, you might confound yourself. So you have to know the rate. So that's just an overview, مش questions. هلا راح أفتح لي questions. Okay. So for this case, we have a 20-year-old housewife. She has had her labor induced at 38 weeks because of growth restriction. This is her first pregnancy. On admission, the cervix was 4 centimeters dilated. Of course, whenever we admit the patient to the labor ward, we do what we call an admission CTG. And the midwife was concerned about her CTG, and she called you as a doctor to assist her. I presume this is a clear presentation. That's our CTG. Would anyone care to tell me what's the abnormality in the CTG? Hassan?
يس دكتور. دكتور بنشوف في deceleration أول شيء عند المريضة it shouldn't be there والvariability ممكن minimal to moderate.
Minimal to moderate.
ومش شايف أنا acceleration.
طيب. Does anyone else have other answers? You gave a partial answer, not a complete answer. You were not wrong, but your answers were not complete. ولا.
هون بنيجي بنعمل زي مقارنة بين اليوترين كونتراكشن البيكس وفي يوترين كونتراكشن وبنشوف في بما انه هون عندنا ديكسلريشنز بنشوف انه حصلوا مع بعض في بينهم وقت كذا فنبين عندنا انه كل الديكسلريشنز كان at the same time صاير معها uterine contractions وهالإشي بنسميه اللي هو early deceleration. طبعا هو إشي abnormal يعني أو لا عفوا هو إشي reassuring unless إنه كانت deceleration deep or associated with other CTG abnormalities. أتوقع هون ما في acceleration فبنعتبر هون إنها pathological لأنه ما في يعني في other abnormalities اللي هي absence of accelerations.
Okay. أنصحكم نصيحة بس نخلص في paper هي ورقتين بالضبط اسمها The NICE Guidelines for Intrapartum Cardiotocography. Okay. هي جدول افتحوا بس اقرأوا okay عشان CTG. هلا in general what I would say هلا أول شيء عشان حسن حكى عن variability صح؟
Yes دكتور yes.
Okay. حسن, what's the normal variability?
النورمال يعني المودريت دكتور
moderate
المودريت
yes.
يعني من 6 to 25 beat per minute.
Okay, fair enough. ناخد this portion. This is around 125 صح البيزلاين هون. Do you agree؟
البيزلاين
مش الخط تبعي على 125. Do you agree؟ تقريبا
130 125.
اوكي.
yes.
والخط هون اللي على التوب وين؟ slightly above 140 يعني 145 تقريبا صح؟
yes.
So these are 15 beats per minute. Are they normal?
طبعا يعني ضمن الرينج.
اوكي ناخذ محل تاني بس نتأكد. هون احنا على 140 صح؟
yes.
هون احنا تقريبا 155 150 thereabout. These are 10 and this is also normal, so there's no abnormality in variability. Are there decelerations? Yes, because they're more than 15 beats per minute for more than 15 seconds. How do you determine they're early? Yes, the nadir of every contraction, every deceleration is with the peak of every contraction. If we draw lines, هاخد إشي أعمله كمسطرة بس ثواني لأن للأسف OneNote ما بعطيك مسطرة. هاي خط هاي خط مش راح أكمل على الباقيين بس in general every trough coincides with a nadir. So these are indeed early. These occur with more than 50% of the contraction. Yani if in every contraction, every other contraction, there is a deceleration, this is less than 50%. If it's more, this is more than 50%. So these are called recurrent early decelerations. Now, non-recurrent early decelerations are normal in labor. Recurrent are not, but they're not really that pathological. They're just an abnormal findings. Do we have to have accelerations in every interpartum cardiotochogram? Are accelerations a must? Live?
Yes, doctor. لازم at least 2 accelerations.
That is correct in cases of non-stress test, which is the test that is done antepartum for fetal well-being. As a part of, for instance, the biophysical profile, you have to have contractions. But in labor, you don't have to have contractions. Okay. Although if you do have a contraction, that rules out fetal acidosis and compromise by 100%. But you don't have to have these in every single case of labor. تمام؟
دكتور ممكن تعيد ليش إنه عادي لو ما كان في accelerations؟
We do fetal heart tracings in 2 situations, either intrapartum or antenatal. Intrapartum يعني during labor, when the lady is already in established labor. صح? The other type is called non-stress test. Non-stress test is when you do it in a lady that's not in labor for fetal well-being. يعني زي لما بفكر أعمل biophysical profile, for instance, واحدة عندها oligohydramnios and I want to do a biophysical profile, راح أعمل non-stress test. A lady had mild spotting and she's not in labor, I'll do a non-stress test. In those cases, you have to have at least 2 accelerations in 10 minutes. That's called a non-stress test. This is called a cardiotochogram. These are different situations. مش راح نجيب لكم إشي زي هيك تركب الامتحان الإعلامي يعني. مش راح أسأل عن أسئلة كتير، راح أفرجيكم صور لأنه ما فيش وقت. What do we call this tracing? Samah.
Sinusoidal pattern.
Yeah, this is sinusoidal pattern. This is one of the worst patterns you'll ever encounter. And is there a drug that's commonly associated with this pattern, or certain conditions that are associated with this pattern?
Usually severe fetal anemia.
Yes, severe fetal anemia and high drops, and sometimes it's due to medication. This medication is very commonly, especially in the Middle East, given intrapartum, and it might cause a sinusoidal pattern. هذا بعرف شو اسمه. Another hint about this drug. This drug has different names in the UK and the US, and should not be given to any patient at risk of seizures, because one of its metabolites lowers the threshold for convulsions. حسان رافع ايدك ولا ناسيها؟
لا دكتور نسيها.
Okay. So pethidine causes sinusoidal patterns sometimes. That's one of the causes. That's another tracing. That's omen for about 2 weeks ago, actually. What do we see here in this tracing? Would anyone care to tell me? Hassan?
دكتور عفوا فيها عندنا two decelerations early deceleration عشان جيت على نفس تقريبا على نفس اليوتراين contraction peak.
Okay. Does anyone have any other answers? ولا؟
هون لا الكونتراكشن الديكسلريشنز ما صار at the same time with الفيتال ديكسلريشنز. اليوتراين كونتراكشنز سابقين شوي الفيتال ديكسلريشنز، وبتوقع بنسميها هون late deceleration.
Yes, this is recurrent late decelerations. If you draw a line, the deceleration starts after resolution of the contraction. So these are late. Why recurrent? Because they occur at more than 50% of the contraction, with every contraction. I'm not going to discuss this one because it's harder for you guys. Here we have two types of decelerations. What types of decelerations are they? What's A and what's B? And this is going to be the last one because I know, guys, you're overloaded, especially for Ramadan. So what's A? How about we go to an easy? No, I don't have. That one was deleted. Hassan?
يس دكتور.
أعطيني واحدة منهم، نقي واحدة واحكي لي شو هي.
I think P is a late deceleration.
تمام.
و A might be variable. I don't know. صح مش متأكد.
Okay. Fair enough. في أي حد عنده أي جواب تاني؟ طبعا عمره ما راح يجيب لكم بالامتحان. أنا بس هون عشان أقدر أعمل زوم على الإيمج. بالامتحان راح تلاقوا ستريب طويل موجودين فيهم كل كونتراكشن راح يكونوا كلهم من نفس النوع. فما تخافوا. أنا بس هون for the purposes of illustration. That's it. So let's discuss the first contraction. بدي أرسم البيك تبع الكونتراكشن. That's the peak. What's the nadir of the deceleration? That's the nadir. So what type of contraction would it make it? What type of deceleration would it make it? Hello? عفوا بس ما سمعت هلا صوتك قطع. So this is late. Yes, this is late. Now the next one is the tricky one. If we do the same. I'll give you a hint here. What type of deceleration is this one? Philip.
يمكن variable.
يمكن variable. ليش variable؟
لأنه on both sides كان في عنا يعني ما بعرف مش عارف كيف أوصفها صراحة.
Okay, we call them shoulders. We call this phenomena shouldering. كتاف. So this is indeed variable deceleration. So in general variable deceleration أنا لما بدي أشبهها بدي أوصفها لواحد زي الإيجي. مش في إشي عندنا اسمه complete heart block أو complete AV dissociation. لما ال P wave ملهاش دخل بال QRS بتاتا زي كأنه كل واحدة ماشية لحالها بفريكونسي لحالها. نفس الشيء ال variable deceleration. بس أحيانا ما عندكش غير واحدة أو تنتين فمش تقدرش تشوفها. فإن general that's why this happens in variable deceleration. In general, in the umbilical vessel, we have veins and arteries, correct? Which are easily compressed, the veins or the arteries? Samah?
The veins.
The veins. So, Samah, let's just disregard that this is a fetus. Let's presume this is an adult human being. My analogy to the umbilical vessels are the aorta and the inferior vena cava. Fana?
Okay.
I lay someone down, I compress their abdomen to compress their vessels. What's the first vessel to be occluded?
Abdominal aorta.
Which vessel has the lowest? Yeah, the vena cava is easily compressed. What happens if I occlude the vena cava for someone?
Decreasing the return.
Decreasing the preload. Okay.
Preload, yes.
So if you decrease the preload, what would the heart do to compensate?
Increasing the contractility.
How? Contractility has two parts. Volume and frequency, صح?
Yes.
Volume is limited, لأن already occluded the preload. So the only way is to cause tachycardia. صح?
Yes.
So, if something compresses the umbilical vein, the umbilical cord, the first vessel to be occluded is the vein. So the fetus will respond with rebound tachycardia because the artery is still there. When the pressure increases, what will happen? The artery will be included. Let's presume it's the aorta in our analogy. And if you occlude the aorta, peripheral vascular resistance will increase. صح? And always, whenever you have increased peripheral vascular resistance, the response is bradycardia. إذا مسكت واحد حطيت clamp على الأورطة, that's what will happen. There is a period of total occlusion where the heart rate will be sort of stable at that limit. But when the pressure starts being relieved, the first vessel to reopen is the artery. So you'll have return to the normal heart rate, but because the vein is still occluded, it will offshoot. Only when the veins reopen or the pressure on the vein relieved, the heart rate will return to the normal baseline. And that's why, of course, this is the baseline. And that's why you usually have peaks before and after variable deceleration, which we call shoulders, just like the shoulders of a mountain or a valley. It's simple first year physiology, but you guys forget it. وضحت الفكرة؟ So first, we occlude the vein, so the heart rate increases. Then the artery will be included, so you'll have bradycardia. When the pressure is relieved, it starts being relieved from the artery, so the heart rate increases. And when the pressure is totally relieved, you'll have return to the baseline. Okay. So that should do it for today. I don't want to overload you with any more information, guys, for today. Does any of you have any questions before we end our discussion for today? And I have a couple of words before we end our discussions. تفضلي سماح.
Doctor, when we discuss the partogram, if a female in preterm labor and has obstructed labor, do we give tocolysis and steroid and tocolysis, or we just do cesarean immediately?
She has obstructed labor, and she already progressed in labor and it's obstructed?
Yes, but it's preterm.
No, if she's already in established labor, that's it. You deliver her. We use tocolysis if the lady is still not dilated, or she has 2, 3, 4 centimeters dilatation. We might resort to tocolysis. But if she already is progressing in labor, she's 6, 7 centimeters dilated, that's it. She's already in established labor, and this is obstructed labor. This is very unlikely, especially in preterm, because remember, preterm babies are very small. So how would they obstruct in the first place? Yeah, sometimes even transverse babies is at 24 weeks, you'll deliver them vaginally, easily. Because first, they're unlikely to survive. You don't want to do unnecessary cesarean section for a baby that might die, and it's usually very small and easily delivered.
تمام دكتور. تمام شكرا.
عفوا. So, does anyone have any other questions? Okay, there seems to be no further questions, so just give me 30 seconds. I want to say something. So today is my last discussion with you guys. I hope at least I did not bother any of you or disrespect any of you unnecessarily, because that was never my intention. Sooner or later, you're going to be our colleagues. And I'd really rather have educated, scientific, and respectful colleagues. I hope whatever I tried to tell you has been clear and concise. Please remember, medicine is an ever-changing science and it's not cohesive. So don't expect to have the same answers being accepted by whomever interviews you in the future. And please try to learn by the scientific method. Scientific method does not entail hearsay. Hearsay is not part of the scientific method. Try to always go back to the primary reference and try to attain reputable references. Not any journal or any article is a valid scientific article. And I hope you guys all the best.